the question of timing of response has become an important question, I think, in the field, since the adoption of venetoclax plus HMA as a standard regimen after its approval. I think there's a lot of historical experience using the hypomethylating agents, so one of the chemo drugs, as for the last several years, and I think clinicians are used to kind of how to manage that, how many cycles to give before assessing a response, or how many cycles to give before maybe moving on to try something else if they don't feel like it's working. And so that led us to ask the question of how that appears to be in the setting of venetoclax-based combinations. And so what we did was we combined data from 2 clinical trials using venetoclax combinations, one which was in combination with hypomethylating agent, the other is in combination with low-dose cytarabine. We were looking to see after whether patients should continue for several cycles, or if one should stop after a certain amount of cycle. We were looking to see if there was any baseline data that could help us guide those decisions clinically. So we found that actually, as expected, most patients achieved remissions fast, which is what we all knew from the manuscripts that have been presented, the data that's been presented from the 2 trials. In most cases, remissions are achieved in the first cycle or 2 cycles. What we also found was about a third of remissions occurred after cycle 2, and to some degree, that was a surprising finding, at least to me, as my thought had been that patients were achieving, higher percentage of patients were achieving the response early. So that was quite interesting. We also did analysis looking at maybe baseline features that could help predict who would maybe benefit from additional cycles of treatment after cycle 2. And I think that was also informative. We looked at some subsets of disease, and maybe which subsets might be more likely to achieve a response early. So I think that was useful data. The certain mutations like IDH, NPM1. I think these have performed very well on the parent studies, so to speak, the phase 1 and the 1/2, the LODAC and the hypomethylating agent studies. So no surprise here, we saw that patients tended to achieve robust complete remissions and quick in those contexts. I think the other analysis showing that patients who had a secondary AML and those that didn't achieve blast clearance early were less likely to achieve a later remission, I thought was perhaps the more relevant piece of information. So I think this is certainly an intriguing data set. It's obviously a data set that's derived from 2 controlled clinical trials, right? So they're definitely they're not real world populations, so to speak. And I think that would be interesting to start looking into whether or not you see similar things, or what we're seeing in the real world evidence side of things, where a lot of these practice patterns can be tested. I think it would be interesting to see if this is more generalizable, because I think this has the potential to impact how we give the regimen, and I think that's important to disseminate to clinicians. Yeah, I think what really this data shows us is that I think you have to take kind of the patient on an individual level, and you need to think about the patient's baseline disease characteristics as well as their response to treatment when you're thinking about how long to give them, venetoclax-based regimens in order to get a response. So in other words, kind of personalize these decisions as to when to either decide to move on to something else if you don't feel like treatment's working well enough, or to continue and push to try to get a response at a later time. And this is really pertaining to those third of patients that are not achieving the response within the first 2 cycles, like you see in the majority of the remission.